This recording is about White Gandalf, who is a magician and has a staff and can smote hundreds of thousands of beasts with one wave of his magic wand. Still needs to continue teleporting to various places in the Underverse and needs to marshal his forces of good to defeat the forces of evil which rise yet again. And specifically what we're going to be talking about is antibiotics, which are the single most potent intervention in the history of mankind. Antibiotics have saved more lives than anything else that we have utilized as physicians, even though they've only been around for about 80 to 90 years. Vaccines have probably prevented more deaths, but antibiotics have saved more lives. And that doesn't include all the herbal and home remedies that were utilized by witch doctors who, in fact, do know herbs and do utilize therapies that involve topical antibiotics. So I'm going to address a few things, the first one being antibiotic stewardship. So antibiotic stewardship is a concept invented to allow us as physicians to be better and to prevent people from being treated who need it, and to save those antibiotics for people who don't benefit from it. So what exactly does that mean? It doesn't sound very logical because it isn't. Basically, it's a specialty of physicians who is mostly devoted to controlling the use of certain big guns, quote unquote, for severe infections in order to try to prevent the emergence of antibiotic resistance. What's the problem with that? Well, the problem is that resistance emerges in infections if you don't treat the infection. A fully treated infection, by definition, is not going to generate resistance because the bugs are dead. Now, bugs are killed not by the antibiotics, but they're killed actually by the immune system. And this is proven by the fact that we actually have two kinds of antibiotics. We have bacteriostatic and we have bactericidal. Now, most antibiotics are both. In a low dose, they are bacteriostatic. In a high dose, they're bactericidal. But there are some that never really turn bactericidal. They just inhibit the bugs enough so that the resistance or your immune system takes care of the problem. Why is this important? Because people who are immune deficient cannot clear infections. So no matter how many antibiotics you give them, eventually they will succumb to the infection, or they will live long enough so that something else kills them. And there's actually a fair number of people out there who drift around hospitals like that. Does that mean their life isn't worth living or something else? No, I'm not passing value judgment. It's just a simple physical fact that they are chronically infected. These are the individuals who actually are the mechanism for developing antibiotic resistance. Somebody who comes into the hospital and they have a pneumonia and you give them some antibiotics, even if the pneumonia is severe, they walk out, they are cured. They're not going to develop resistance. They're not going to develop anything. Somebody who has a urine infection and you treat them suboptimally, they can develop antibiotic resistance. And this is where the problem comes in. This is the dividing line. So let me preface all of this by saying that I started out drinking the Kool-Aid. I was actually taught at a ivory tower educational institution, one of the most prominent in the United States and in the world. And I was also surrounded, taught by exceptional people. I can say that without any sarcasm. And I was also at a stage of my life where I thought just being a doctor was the greatest privilege. I couldn't believe that I was permitted into medical school. And therefore, I was going to accept and learn and understand everything that I was taught. But I soon started to become aware that some of this didn't quite make sense. In other words, the same effort that I was putting into understanding everything wasn't quite mirrored by the people who were telling me things. And so what this is called is the process of first you learn to read, but then you learn to read between the lines. So you have to start understanding that after a while, what you are being told doesn't fully make sense. Well, one of the things that didn't fully make sense, though, is that you should select your drugs and you should be very elegant and try to have the most precise bullet for what your problem is. And especially as a person who's scientifically trained, that one I went with for a long time, because I felt that if I'm smart enough and if I learn enough about antibiotics, I'm going to know exactly what antibiotic to use. And if I got it wrong a little bit, then the culture will tell me, and then immediately afterwards, I'm going to be able to fix it, and I will pick exactly the right one, which even has the right side effects, and therefore I'm going to be just the best physician ever and fix everybody. There's a problem with that. It doesn't work. Why doesn't it work? Well, it doesn't work because of all kinds of considerations, one of them being it's the real world. People have different kinds of immune systems. And different areas of the body have different kinds of infections. For example, if you're talking about your lung, you're going to have maybe, pneumonia from pneumococcus. Well, if you're talking to urine, it might be Klebsiella, which has a different resistant patterns. And more than that, some of the antibiotics will not be secreted into the urine. So, for example, you are going to, if you give somebody levofloxacin or Levaquin, it'll treat the urine infection. Maybe well, maybe not. But if you give him another fluoroquinolone, it might not be excreted into the urine. So although you have a good drug, you need to know the individual characteristics. Furthermore, in the real world, you also deal with corruption. In one particular hospital that I worked, which I won't name, which might be in Santa Rosa and might be called Memorial Hospital, for a number of years we were forced to use a drug called Avalox on everybody who was admitted to the emergency room, because the hospital developed a contract with the manufacturer. Well, it turns out Avalox is not secreted into the urine, so everybody who came in who had a urine infection got deathly ill. And since 80% of elderly people who come in with altered mentation do so because they have a urine infection, which will put you on all fours if you're elderly, even if you're otherwise perfectly healthy, then all of these people ended up in the ICU, and it took days of fighting to switch them to a drug, an effective drug such as Zosyn. Now, these are technical issues, but they have to do with the practice of medicine and the mess that we're making. So basically what happens is, the second thing is, a lot of the antibiotics or a lot of the infectious agents already have a resistance. For example, if you're talking about your rectum, E. coli, if you have an intestinal infection or something that extrudes from there, it festers. So by the time you get to it, there's not only Klebsiella, but there's also Pseudomonas, and there's E. coli, and all these things communicate. And the way that bacteria actually develop resistance is they talk while they have sex. They have sex a lot. It's called conjugation. And they talk. In other words, they exchange genetic material. That's not for reproduction all the time. They literally just screw. And as they're doing so, they give little bits and pieces of material which teaches both of the bugs what the other one knows. How that works, we don't really understand fully yet. Some of it is random, and probably some of it is not conscious. There's no rhyme or reason to it. But whichever ones of the pairs exchange the right combination of materials survive, and so then they start breeding. They do another thing, which is brilliant, however, which is actually sort of deliberate, which is they pass plasmids around. And this is a mechanism that appears to have been specifically involved to respond to these kinds of insults, and because it doesn't make sense any other way. And these are basically like flyers that they pass around instructions on how to get around antibiotic resistance and other insults. These plasmids we used to think were only passed around by gram-negative organisms, but in fact they're passed around by all bacteria, we now know. So because of that, very quickly, within a generation to 2 generations, given the right conditions, a strain of bacterium, especially some of the worst actors like Pseudomonas and Klebsiella, which are not only hardy and already have some built-in antibiotic resistance, but also tend to be more active about passing information around, they end up acquiring antibiotic resistance. So what does this mean? It means that when you go into the hospital, there's going to be resistant bugs. As you may or may not have heard, many places there's MRSA, which is endemic. There's also VRSA, although it's not that common, because it turns out that the wild types usually are the best and the strongest. And once you start passing around these characteristics, although it sounds like a really bad thing, the thing is that those bugs, once they develop these resistances, actually in some other way end up being compromised. So all these horrible things that you hear about also have some caveats with it. Anyway, aside from the technical details, the other problem is that most of the hospitals these days have horrible infection control. We've gotten careless. I actually don't remember the last time, 50 or 60 hospitals I have worked over the years in various places in the US, and I don't remember the last time that I really saw proper isolation measures. During my training back on the East Coast, I used to, but not on the West Coast and not recently. And why that is because I think we have gotten somewhat complacent, because we have good antibiotics. We also have a specialty which is basically devoted ostensibly to helping the average physician to selecting and administering antibiotics correctly. And for, I guess, some of my colleagues, they're not comfortable with selecting these antibiotics. In my case, I do have the training. I specialized in, or I do have engineering training, and also have spent a lot of time familiarizing myself with pharmacology. So throughout my career, I tried to be judicious about the use of antibiotics and also following their effects. So I ended up doing most of it myself. Turns out, however, that there is a specialty which would end up, whether I liked it or not, telling me what to do. And the theory for this is that if we keep certain antibiotics from being used commonly, then we prevent resistance. The problem is, it doesn't make sense. Resistance develops from not using antibiotics. It develops from not killing an infection. So if you are going to use the correct antibiotic to kill an infection, or if you are losing to an infection and you need to use a bigger gun, the worst thing you could do is not use the bigger gun and kill the infection. Because if you partially treat that infection, even if the person eventually recovers from the insult, not only will they suffer in the process, but by the time they heal, they will have infected other people with the resistant organism that I had problems treating. This is the problem. Not only that, but there's large amounts of immunocompromised patients in hospitals. Sometimes they are isolated, but unless it's an overt or life-threatening issue, they generally are kept in the common population. They are often treated for chronic infections such as cutaneous infections, things that eventually you're going to lose to. And because they are being treated for limb saving or various other things, especially diabetics, those infections will have been there for months, and therefore they will have both developed resistant organisms. And those organisms are going to be under skin and splayed all over. Is there a solution for that too? I'll get to that in a few minutes. But basically what it comes down to again is this concept of learning to read and then learning to read between the lines. Withholding antibiotics does not work. What does work is targeting the antibiotics correctly, understanding, getting a culture, figuring out the resistance pattern, and then watching your patient very closely and making sure that they're responding as you would expect, otherwise escalating the coverage. Usually, I would wait about 48 hours before deciding to escalate coverage, but if somebody didn't respond at 48 hours, I would immediately do something. Sometimes I would be stopped, sometimes I would start a medicine and would be forced to stop it. In a couple of cases, I ended up losing a job because of it. I'd rather do that than have to contend with knowing that I injured a patient. The point is that clinical outcomes are 100%, at least with infections, if you're judicious with the use of antibiotics. I also think that infectious disease should be consulted very carefully, and I also think that the concept and the practice of antibiotic stewardship, the way that it is practiced today, should be abolished. It is an anathema. It is completely logical. As confirmed by my buddy Guido, who is a mafioso. I'm sorry if I'm engaging in stereotypes. Io parlo italiano, okay, or rather I don't speak it, but I understand, so please, maybe I can be forgiven. But I think a lot of mafiosos have something to teach us, just like the Yakuza. And the most important thing that they probably can teach us is if you're going to kill something, kill it good. That means a double tap. So when a mafioso goes and they go execute somebody for the capo, like with The Godfather, they first tell you that you're going to have some cannolis and have a nice time in a restaurant a little bit out of the way. But then as you're being dragged into the alleyway, they're also going to first put a bullet in the back of your head and then follow it up with a second one. That's because the second bullet only costs about 80 cents, but if you stand up after the first one, because by some miracle you survived and then you testify in front of the grand jury, the consequences are bad. So it's the same with antibiotics. If you're going to kill something, kill it good. Don't be worried about intestinal flora or politics or anything else. This brings up a number of things, especially the COVID epidemic. During COVID times, I saw a lot of physicians basically stop treatment and stop the use of antibiotics because they were told that COVID was what was causing the problems. And they failed to treat conventional infections or the infection that resulted from COVID rotting your lung. That's how COVID works. It rots tissue. It's hematogenous spread and then necrosis of tissue. So it's basically like microabscesses in your lung. If you don't treat it, then the patient's going to die. And a lot of patients that I didn't treat died. Whoever I treated, I immediately started antibiotics. They were okay. I was admonished a number of times for it. And statistics show that there was a drop of 20% in the use of antibiotics during COVID times. A lot of physicians are proud of this. This is being extolled as a possible beginning for more rational use of antibiotics. Well, let me tell you, it's garbage. Bullshit. Antibiotics should be used like vitamin C. It is a lifesaver. Antibiotics also, as I stated, should not be used alone. That's how I started my career. I had a lot of therapeutic failures before I understood. You don't go around and just give one antibiotic. You cover everything that could be possibly there. If you need to use 4 antibiotics, that's what you use until you figure out what it is or until the patient responds. It's not elegant. It's intellectually very uncomfortable. It's just unsettling as a scientist, but that's what you do because that's what you need to do clinically if you want a 0 outcome rate. And I guarantee you that not once in my career did I ever send home a patient with a resistant infection unless they had it when they came in. And I did my level best to treat that infection if they did come in, including nuking them with the correct antibiotics. This brings up a number of other issues, which is our FDA is an organization that is much hallowed and touted, but it has some real challenges. One of them is one of the most effective antibiotics that we used to use like water back in the old country is no longer used. That's called chloramphenicol, because there was a 1 in 50,000 incidence of a reversible reaction, bone marrow depression. Reversible. This is an antibiotic that covers a lot of things. Now, it's a dangerous tool to bring back because it's a blunt tool. But at the same time, it's really astounding that it hasn't been brought back and that it's not in wide use. It's dirt cheap. It's one of the best antibiotics, including the newer ones. It's just incredibly potent. And it's a shame, but there's no profit in it. And this is where somebody says there is some level of conspiracy. Although I do believe in Hanlon's razor, I also believe in the greenback. And those who hold it do make decisions on its basis. I'll get to something a lot more serious right now, and this is the end of the presentation, but it's a very, very short and very important topic, which is most of the antibiotics that we use stupidly and pointlessly. The vast majority of significant infections we have in life are not in your lungs, they're not in your kidneys, and they are not in your liver or any inaccessible place. They're outside, and they're on your hand, on your feet. They're surface infections. How do we treat surface infections, including in diabetics? We give them IV antibiotics. This is like basically, trying to send a 911 message through the US mail. Not only is it delayed and the message is diluted, but it's actually pointless. Topical antibiotics, which I have used extensively in my clinical practice, are far more effective than any IV antibiotics. If you have a surface infection, if you have a skin infection, things like betadine and metronidazole gel will give you cidal effects hundreds of times higher without tissue necrosis or damage as compared to IV antibiotics without the systemic effects and without the risk of systemic antibiotic resistance. Remember, most of us are colonized with bugs, and if we give these antibiotics stupidly and without point, we have low tissue levels in various areas of our body. Those bugs that are sitting there can develop antibiotic resistance. We've been doing this for a long time. Why it's so difficult for people to just understand or to see the obvious, I don't know. Maybe they just don't have the experience, or maybe they have never considered it. But that does not excuse the fact that topical antibiotics work far better for a topical problem than IV antibiotics. That includes things like infected hands, dog bites, cat bites, all of those things. If they are addressed in the first, few hours of the infection, they prevent it. All you have to do is smear on some antibiotic gel. It gets absorbed. Tissue levels are enormous. Nothing will happen. Conversely, if you have a human bite, for example, to knuckles, because you smashed your buddy in the face while you were drunk, you're guaranteed to have a horrendous infection that can actually turn necrotizing fasciitis. So why would we not teach the populace and make these antibiotics available? They're not going to cause antibiotic resistance. If they don't work, the patient will still have to come into the hospital. And probably somewhere around 90% of infections that we end up treating with IV drugs in the hospitals would be preventable or would be treated at the earlier stages. So this concludes my thing on antibiotics. Hopefully, again, it's instructive. It does have impact both on your life, and hopefully some of my colleagues will start thinking, which unfortunately sometimes I find they might not do.